welcome everybody to this all-important training program. And without any further ado, may I please crave our indulgence as we stand. We're going to recite the second stanza of the old national anthem. We adopt that as our prayer, O God of creation. O God of creation, direct our noble cause. Lord, our justice to follow, and leading us to truth. Spirit of the light and faith, to build a nation where peace and justice shall reign. Amen. Thank you very much. While we are still standing, we take the national anthem now. Nigeria WED02. I think that one will be played for us so that we can follow. Those are from baby, from King brotherhood we stand. Nigerians all proud to serve us a great motherland. Our flesh shall be our city, our truth and justice reign. In peace all heart to honor, and peace be God's King. To honor our we don't sing. Oh God of creation, that is our one request. Help us to build a nation where nobody is oppressed. And so in this our family, Nigeria shall be blessed. For the church and we get to achieve the best in the sciences, till the nation change the world. Such a lesson making impact in the nation is a goal. Such a lesson making impact is a goal. To compose the chairman of the organizing committee or the director of the center. The director of the center. The chairman of this event, the chairman of the organizing committee for this program, and the consultant pediatrician, that's Dr. Francis Akikume. Then the chief medical director of the University of Medicine, Dr. Michael Bala. Then the fourth person, deputy director, Center for Health Professions and Biomedical Education, Dr. Janet Ibaro. Then we also have Etimoko Tuone. I won't be paper. Professor Akubola. I'm telling you, second. On behalf of the Vice Chancellor of this great institution, I welcome everybody to this training. This opening ceremony is more like the climate setting for a 3-day training that we will be having here. Let's set the climate right, and then we understand the significance of what we have come to do. I want to recognize, in absentia, the Vice Chancellor of this university, Adeshegun Fatusi. Please a round of applause for him. He may not be here physically with us, but he's still here with us. Because representing him at this occasion is the Deputy Vice Chancellor, Academics, Professor Rose Angela. Please a round of applause for her. So she's wearing 2 caps here today, representing the Vice Chancellor, and also in our official capacity as the DVC account. She will also be relating with us. Again,
Let's welcome her with a resounding applause. Also in our midst this morning, when you check what we are doing, the CMD is also very much with us. That's the Chief Medical Director of the university. I recognize Dr. Michael Dalla. Please, Igala. And in our midst also is the Deputy Director, Center for Health Professionals and Biomedical Education, Dr. Janet Igbaro. Please give a round of applause for her. For this event to be holding, a lot of background work has actually gone into it. And the person heading the organizing committee that has made it possible for us to gather here this morning, Chairman of the Organizing Committee, I recognize Dr. Bola Francis Akinkunmi. He has been running up and down to ensure that this works perfectly well for us. Also, last but not least, a man who is dedicated to what his hands are found to do. Distinguished ladies and gentlemen, I want us to welcome officially to our midst our main facilitator, a professor of international repute. Please let's put our hands together for Emeritus Professor of Pediatrics Care, Professor Olugbenga Akinbola. You are welcome, sir. Distinguished ladies and gentlemen, without wasting any further time, I would like to call on the director of the center to please give us our welcome remarks. Please let's appreciate her.
Good morning, ladies and gentlemen. I want to appreciate our Vice Chancellor and the person of Professor Adeshegun Fatusi. I also want to appreciate our DVC, ACAD, and she's standing in for the Vice Chancellor. I want to appreciate you, ma'am. As well, I want to appreciate the CMD, Dr. Bala, Michael. I want to appreciate you, sir. Then our emeritus professor, Professor Olugbenga Akinbola. We want to appreciate you. I want to thank the Society of Clinical Care Medicine for making this training a reality. I want to believe that all the participants will enjoy the time of the training. I'm standing in for my director, that's Professor Kayode Oshunbade, who sent his greeting that he wish you a wonderful training. I want to believe that henceforth is going to be a yearly thing. Because initially we had one in 2021, and that gave back to a bigger stimulation now. Because that is the mind of the Vice Chancellor, to have an integrated clinical stimulation center. I will wish the participants to go around after the training to look at the buildings. We have some other stimulation lab for maternal and child. So I wish you a wonderful training, and we hope that you will communicate this training to other colleagues, so that when we organize it next year, we have more participants than this. So I have a wonderful training. Thank you very much.
So, Immaculate Apalaba, please, a round of applause for her. And the next item on this agenda is for us to know why we are here. What is the essence of this particular event? And I will call on Dr. Akinkunmi to briefly give us an idea of why we are here. Please a round of applause for Dr. Akiko.
Good morning, ladies and gentlemen, once again. I'm standing on the existing protocol. I want to welcome all of us here. The essence of pediatric critical care. When I come in contact with Professor Akingbola, who I will still give the mic to give us some of the essence. In Africa, out of Sahara, there are very few places that have ICU space for children. In Nigeria, maybe there is none. If there is an ICU space, maybe in UCH, we want ventilator at times. The concentration is critical care for adults most of the time. And when children have conditions that require critical care, there is no place to send them. And prompt and adequate care for children in critical condition usually yield positive results. So having good knowledge of this will help many of our children that are critically ill to survive, while we'll make them stable before transferring to centers where we can have intensive critical care, which we don't have yet. So the essence of this training is to equip our pediatrician and general practitioner with adequate skill and knowledge in pediatric critical care to sustain these children and so that we can transfer them to where they can get better care, and to broaden our knowledge, open our horizon of telling others that we need pediatric critical care. It's my hope that in the nearest future we'll have pediatric critical care centers south of Sahara and in Nigeria. And I believe many of the participants here will champion the cause, having had this kind of training. So at this junction, I would want Professor Akingbola to tell us more of what he has in mind.
Ladies and gentlemen, the CMD, the Deputy VC, my good friend Dr. Kalaba and Dr. Akinkumi, of course, all the participants, it's been a pleasure to be here. Dr. Akinkumi actually has mentioned the rationale for having a training like this. The Society of Critical Care Medicine realizes that not every pediatrician out there is trained to take care of patients that are very sick. So they came up, I think in the 70s or 80s, they came up with this course called the Pediatric Fundamental Critical Care course. And it's actually a course that it's performed or conducted all over the world, including the United States. Now, in 2021, I approached them and said, we need to have a similar course in Africa. And they were gracious enough to sponsor the first one that we conducted here at UNIMED. My rationale for doing that is that, like Dr. Akinkumi said, we do not have a pediatric intensive care unit properly established in Nigeria. As at first count, I think UCH has a 6-bed unit now, of which only 2 or 3 beds are functional. And I understand that there are some private hospitals in Lagos with a pediatric intensive care unit. So what we are trying to accomplish is that while we are waiting or hoping that at some point in our national history we will have PICUs, it is appropriate to equip the pediatricians who are on the ground with the appropriate knowledge and skills set necessary for the care of a patient who is critically sick. So that is why in 2015, I started having these programs at the University of Ibadan, somewhere in Lagos, and finally here at UNIMED. So I truly congratulate all of you who are here in the sense that you are pioneers. What we are saying is that at least we should improve the chances of any pediatric patient who is very sick, the chances of survival, by equipping the general pediatricians with the necessary knowledge. That was the objective of the Society of Critical Care Medicine, and it's very helpful. So we are going to be going through some of the common things that you will see as pediatricians out there, with the emphasis on early recognition and taking appropriate management steps and acquisition of the necessary skills that you require and the knowledge base to perform effectively, even without an intensive care unit as yet. So I want to thank the VC and the university for making this possible. This is not the first time, this is the second time. And again, I always say that this university has foresight when it comes to medical education. And I'm not aware of any institution in Nigeria that has a well-established simulation lab. So again, thank you for hosting us, and I hope that we will be able to, at the end of the day, make this a very impactful and meaningful training experience. Thank you.
Thank you very much. I appreciate Dr. Akekumi and Prof for giving us insight into the essence of why we are here. I want to call on the CMD. So please give us his goodwill message. Please a round of applause.
Let me say good morning to everyone. I'd like to stand on the existing or established protocol. In absentia, I want to also thank the Vice Chancellor of the University of Medical Sciences, Dr. Fatusi, for the collaboration that we're having for this training, who is ably represented. I think my sister is wearing two caps. So I thank the Vice Chancellor and also in the capacity as Deputy Vice Chancellor. I want to say good morning. I also Director. Thank you for
Line mode.
your doing. Let me especially thank Professor Akimbola for remembering his base. So not many people in your situation will remember Africa having had the best of exposure. But I'd like to say we are deeply appreciative that you remember to give back to your base, to your country. Maybe let me inform us that Professor Akimbola is the son of the soil, the son of the town. And one of the challenges people have, especially when they are working in a place, things are working, and they remember their families back home. So that's one of the motivation for remembering Africa. So on behalf of the university, the teaching hospital, the community, we do not take this sacrifice for granted at all. The legacy you are laying, I'm sure in years to come will begin to speak, because one of the best things we can do for anybody is training. You never can tell where the people will take the impact of the training to. So we really, really appreciate you, sir. And let me also thank Dr. Akekumi Bola Francis, who has advertised this event, who has rallied around as if his life depends on it. The kind of prayer he has brought upon me concerning this, one of the things I do is to reply my chat. Even if it's 1 a.m., if I wake up, I see a chat, I want to quickly reply. But I got to a point one night, I almost called him, I think I beg, don't kill me. I said, it was more than it's not the training. We'll come and do the training. Don't kill me before the training, please. He has pushed everywhere to make sure this training is a reality. So I say your good labor of love and sacrifice will be remembered for good. Dr. Misapawa, we thank you enough for what you have been over the years, for your consistency. I know history will also be very, very kind to you. Let me thank all the participants who are here. Those who are not here today, it will have been a disaster. Yesterday I was pushing if we can get some nurses on this program. And Prof told me, no, this is strictly for doctors. So if we are here, despite all the preparation, and none of you is here, it has been very, very discouraging. I hope you know this program is largely free. I can't bring this to you free. Whatever you might have, those for the support, for personally whatever. So that you are here to form of encouragement to everybody. This program had 3 years ago, 2021 precisely, and the report we have from the participants are very, very exciting and stimulating, and I think going forward, this is something we would like to make possible. It can become a yearly event and be out of place. As a doctor, we branded ourselves, we call it NICU, NICU, Complete Special Baby Care Unit. Not many people even realize that the name we give to our NICU is just a name to make us feel good. But they are not really NICU. Maybe we want to call them special care. Maybe a little advanced care. But sir, I want to ask God that the next time we are holding this kind of a training for the University of Medical Sciences Teaching Hospital, the narrative will be different. And we'll be able to say, if we can, at the University of Medical Science Teaching Hospital, we have neonatal intensive care units. We will pursue it rigorously, and whatever it takes, we're going to give to it. Because I believe it's achievable. Sometimes in the year, I think about 8 years ago, we got to a point that we were able to salvage 26, 27 weekers routinely. In fact, we had a baby who was 600 grams that survived. And I don't think we should go back. Rather, we should build on what we've been able to do. When the Master of our Son was doing then, we were very excited to even collaborate with the institution, and some of our staffs were invited back to the United States to have further training. And with somebody of your caliber and with the interest that you have shown, for me, will be something we would like to bring to bear. So I'm assuring you that beyond this training, by the time we come back, the survival for the babies will actually be better. So once again, I want all of the participants, let's put in our best to get as much as possible to this training. Thank you so much.
Thank you very much. Distinguished ladies and gentlemen, it is time for us to listen to the basic remarks delivered by the Deputy Vice Chancellor of Academics.
Good morning, everybody. I'm standing here on behalf of Vice Chancellor Professor Adeshegun, who is absent because he's in far away at Port Harcourt for another meeting which was scheduled earlier. So I welcome you all here with great pleasure on behalf of the University of Medical Sciences and entire management for this 3-day course as organized by the Society of Critical Care Medicine and Intensive Professionals in collaboration with the University of Medical Sciences Teaching Hospital, Ondo. So the course title is Pediatric. It's fundamental critical care support for pediatrician and emergency room physicians. At the beginning, I thought nurses would be there because they're also involved in the care of children. But the CMD said this is just strictly for doctors. And this marks a significant milestone in our continuous pursuit for excellence in the medical education and patient care. I'm particularly delighted to welcome our emeritus professor, Lubenga King Ola, who from the Turin University School of Medicine, USA, who is going to serve as our facilitator. And he's a renowned expertise in this area of medicine, and he has contributed tremendously to the field of critical care medicine. We are so privileged to have him here to share his knowledge and insights with us during this 3-year program or course. I also welcome the Chief Medical Director of the WED02, Dr. Bama, who is serving as the co-host for this event. I can assure you that your support and collaboration has been instrumental in making this course a reality. And we are grateful for your commitment to advancing medical education and healthcare in our community. To all participants gathered here today, I commend your dedication and continuous learning and professional development. Your presence at this course demonstrates your commitment to providing the highest quality of care to your patients, especially in critical and emergencies involving pediatric patients. So as we explore the intricacies of pediatric critical care support over the next 3 days, I encourage you to engage actively, share your experiences, learn from each other and our esteemed facilitator. The knowledge and skills you acquire during this course will undoubtedly enhance your ability to save lives, alleviate suffering, improve outcomes for the most vulnerable patients in our society. And I know that continuous learning and professional development are very essential components of a successful and fulfilling career in the medical field. So by investing in education, training, and skill enhancement, healthcare professionals can stay at the forefront of healthcare innovation, provide exceptional patient care, contribute to the advancement of medical profession. So I wish you all a productive, enhancing, and inspiring experience during this course. May the connection you've made here, especially with our facilitator, help you to gain knowledge and experience and share and distribute your growth as medical professionals and ultimately benefit the patients under your care. So thank you once more for being here and taking part of this initiative. You're all welcome and have a nice day.
We are posting goal, and I want to call on Dr. Abala to give us both of things, initiate the goal. Let's appreciate Dr. Abala. She has always been
Good morning once more. And I'm standing here on behalf of our Vice Chancellor and also the Director of this center, Professor Osumbade Kayode, and the entire team in the center. I stand here to thank everyone. We start also from the Vice Chancellor who brought this initiative. We are saying thank you, sir, and may God give you the grace to continue in this light. We thank also our DVC ACAD, Professor Rosangela Woma. Thank you so much, ma'am, for always being there for us and supporting the administration and making sure that this program, this training becomes a success. We thank our Chief Medical Director, Dr. Mike Bala. I know in not distant time to become a professor. Thank you so much, sir, for always supporting everything that happens in the university. And we can congratulate you too for your new post that has come to. Congratulations, sir, and thank you for making this day also a reality. Thank you so much, sir. We cannot thank you enough, our Professor Akimola. Thank you for always considering UNIMED whenever a training like this comes up. We are very grateful. Last year, June, we had one, which was also very fruitful, and that lasted for 2 months. No distant time, just now, you're here again. Considering UNIMED, we are very, very grateful. Thank you, all the participants. Thank you, Dr. Kinkumi, my friend, who has also been working very hard to make sure that this comes to pass. We cannot thank you enough. Words, in fact, are not enough to say thank you. Thank you so much. Thank you, members of the press, the PRO, everyone here. Thank you so much. Thank you for all of you that have traveled far away to be part of this program and training. Thank you so much. And we also pray that when you go back, you will go back filled with a lot of knowledge and filled with also the spirit of patriotism to help Nigeria. Thank you so much. I will want to make a little presentation. Prof has always been here, and on behalf of my family and in the spirit of the university, we are saying welcome and thank you for your good work which has been ongoing. This is a unique act. It shows the picture of a woman who is using umbrella to cover her baby, who she is nurturing. So, as Prof has been a good mentor and a good patriotic citizen to Nigeria, always considering us, we find it right to say thank you and to continue to nurture and mentor we and others, the young academia and the medical practitioners. Keep it up, sir, and may God bless you as you continue to Thank you, sir. So, lastly, we have to thank the God Almighty who has made it possible for all of us to be here. It's not everybody that went to sleep yesterday that was able to wake up this morning. Even those of us that have woken up, it's still not everybody that is still alive till this morning. So please, with due respect to the high table and everyone here, may we please just show a sign of respect to God by standing. Let's just wave unto Him and say, thank you, Father, for making this day a reality. And at the end of it all glory goes to Him for the success of this training. Thank you, everyone.
That was special. Please, a round of applause. With that, we are almost there. Distinguished ladies and gentlemen, we have come to the end of this climbing session. My name is Isaac Olui, PRO of the university, and we will be taking a group photograph immediately afterwards. Please let's put our hands together.
When you finish pediatric residency, you can become a general pediatrician, or you can go into pediatric subspecialty. I chose critical care, which means patients who are very, very sick, intensive care unit. Now, the purpose of this training exercise is based on the realization that not every hospital, even in advanced Western societies, have an intensive care unit. So you are going to have hospitals in rural areas who are far removed from where the other doctors are. So this course is designed that a general pediatrician should be able to recognize a pediatric patient that is very sick and start life-saving measures before they transfer that kind of patient to bigger centers. So it is done all over the world. And this is the second time that we are hosting this at UNIMED. And there's a lot of echo. I will just reduce that. So, what should you expect? Active learning and critical thinking, which means we are not just going to be sitting down here with lectures. All of you are experienced doctors. So what we're going to be doing primarily will be case discussions and then simulated scenarios, which means I will give you a case and you will act as if you are dealing with a sick child, and all of us as a group will walk through that case. You also have the opportunity for acquisition and practice of life-saving skills. For example, if a child comes to you in respiratory distress, how do you stabilize that kind of patient? If a patient has cardiopulmonary arrest, while you are taking care of that child, can you perform CPR? So some of the skills that you will be learning will be bag mask ventilation and how to perform appropriate cardiopulmonary resuscitation. We are also going to be talking about team training and communication skills. See, when in an emergency, when you are dealing with a patient, for example, has any one of you witnessed an emergency situation? Anybody? Dr. Ikena? Yes. So how many medical personnel, doctors and nurses, surrounding that patient, and what was the case like?
Case was we have about 2 doctors, and then we have and then 2 nurses.
Okay, so make it 4 of you. So that is what we are referring to as the medical team. All kinds of instruction and communication between the team members. So, in summary, in this course, there will be active learning and critical thinking. You will have skills acquisition and practice. And there's also team training and communication skills. Now, because you all are advanced physicians with experience, you are going to be engaged. Okay, that's why I want everybody to have his or her name written. And so we would want you to bring in your own experience and have active communication between you and the instructor. That is what I refer to as participant engagement. So, but finally, you know, all these plastics, they are truly not patient, all the mannequins. So no matter what we do, this is still a simulation. It is not the real thing. So what I want you to do for me as a group is not to keep thinking that, oh, this is just a simulation. Okay? Otherwise, the essence of the training will be lost. So this is what we refer to as a fiction contract. So I want everybody to suspend disbelief and act as if you are dealing with an actual patient. That is when you can truly benefit from what is going on. In terms of the format of the course, there are 2 or 3 basic formats. Number 1 will be, instead of traditional lectures, you have case-based lectures. That is the way the society designed the course. So you have, if I want to teach about shock, I just will not be talking about shock. I present a case. We walk through it. So you have case-based discussions, and then you have simulated scenarios. What that means is that we can create a case with any of the mannequins. Say, for example, the baby mannequin. I can say this is a 3-month-old baby who came in. I will give you the vital signs. I will ask you to go through the steps you will take in the care of that patient. That is the simulated scenario. But before we go into all of this, there's going to be a pre-test, which means you have to kind of gauge your current knowledge of pediatrics and how to take care of a sick pediatric patient. So all the tests, that's what the test is all about. Now, at the end of the training, you will repeat the same test. Now, quite honestly, the purpose of that is to say, where am I now? Where will I be after the training exercise? However, the society that is sponsoring this course have a requirement. If you want to get a certificate of participation, you will first of all take the test and pass the test. And then there's a link that I will provide to Dr. Akinkubi online where they will ask you a sort of questions. And if you do all that, they will send you a certificate. Otherwise, you can choose to just learn and gain the appropriate knowledge, and that will be it. So this test is not for me to award you a degree. It is primarily for you to assess your depth of knowledge in pediatric critical care. And also, at the end of the training, you'll be able to say, well, this is where I am now. So there's going to be some kind of knowledge transfer after the training exercise. Get light. I don't know how long that that's going to be for. So what I will do for now, one thing is, because this is a simulated training exercise, so it's not like your regular lectures. We are going to be doing the case discussion, simulated case scenarios, and so as much as possible, feel very comfortable. Okay, I regard everybody here as experienced and my professional colleague, so there's no I'm there and you are here. So be very free to express yourself. Okay? So I will start out for asking each of you briefly to tell me where you are and what your practice experience is. Dr. Rebecca, right? Morning.
Good morning, sir. Good morning, ma. My name is Rebecca Ogumola. I'm still a medical student.
I see. You are a doctor already. Okay. What in your medical school are you in? Okay. I told Dr. King going to invite some final year students. By the time you spend 6 years in medical school, everything that we're going to be talking here is not going to be new. So you're already, as far as I'm concerned, already a practicing physician. Dr. Lulu, I know you from last time.
Yes, sir.
Yes.
Good morning, sir. Good morning, madam, sir. My name is Dr. Kolawole Lulu. I'm currently an house officer in University of Medical Sciences Teaching Hospital. I look forward to enlightening my knowledge on pediatrics critical care through this conference. Thank you very much, sir.
Good morning, everyone. My name is Dr. Akinwumi Komolafe. I practice in Oba Multi-System Hospital.
Where is that?
Ado-Ekiti.
Ado-Ekiti. Okay.
I'm a pediatrician.
Okay.
Good morning, sir. Good morning, everyone. I'm Oluwakemi Ojuowo, pediatrician. I work at the Federal Teaching Hospital in Ado-Ekiti. I'm particularly interested in pediatric emergency and critical care.
Okay, good.
Good morning, sir. Good morning, everyone. Ernest Ikena. I'm a registrar at University College Hospital. I was actually missed the last one that was held in the teaching hospital, so I said I was not going to be this one.
Welcome. Are you from Ibadan?
Yes, sir.
Okay.
Thank you. Good morning, sir. Good morning, everyone. My name is Nibon Ajibola. I'm a senior registrar in pediatrics at the Federal Teaching Hospital in Ado-Ekiti.
Okay.
I have an interest in pediatric cardiology. So when I saw the course, I was interested in attending. Good morning, sir. Good morning. I'm Okola Azula, the 611 students.
Good morning, sir. Good morning, everybody. I'm Alabama. I'm a pediatrician from the State Hospital of the Ebola.
Good morning, sir. Simon was working out in the final medical student, University of Medical Sciences.
Good morning, sir. Good morning, ma'am. I'm Victor Ajuri, I'm still a medical student of the University of Medical Sciences.
Good. Open your jacket and take your answer sheet for the pre-test. And it should take about 20 minutes. So, do you have your answer sheet, everybody? I'm sure you had this definition yesterday. The definition of respiratory failure, therefore, hypoxemic is when you have a blood gas and your PaO2 on that gas is less than 60. And also, if you have a blood gas and your PaCO2 is greater than 50. And again, like you said, the mixed pattern is common. So when you see babies walking hand, breathing about 60 or 70 times a minute, when their respiratory rate is supposed to be 35 to 40, you
can almost, and the pulse oximetry is reading 90 or less, you can almost infer that what they have is a mixed acid-based, mixed respiratory failure, hypercapnia and hypoxemia. Okay, why do we use 90% as a cutoff? This is because of the shape of the oxyhemoglobin cup. The relationship between the oxygen delivered and the amount of oxygen in the blood. What is the percentage of oxygen in room air? 21%. So if you are delivering 21% oxygen, if you do a blood gas, you should have 5 times the percentage of oxygen delivered in the blood. So if you look at this table here, if you are on 21%, your PaO2 should be 90. If you are on 30%, your PaO2 should be 150. If you are on 40, your PaO2 should be 200. If you are on 50, it should be 250. If you are on 100%, your PaO2 is 500. Now, it's not going to be exactly that because there's some physiologic shunting going on in the body. So you can see why this patient who is in room air and you did a blood gas and your PaO2 is 60 instead of 90, that is hypoxic. So I want you to remember this relationship, that your PaO2 is 5 times the amount of oxygen you are administering. If I'm giving you 21%, if I do a blood gas while you're in room air, if your PaO2 is less than 90, you are hypoxic. And if I give you supplemental oxygen, 30%, your PaO2 should be about 150. That is why yesterday when Dr. Claudia was talking to you about ARDS and defining hypoxemia and shunting, in that situation, when you have a high inspired oxygen administered, and you see a very low amount of oxygen in the blood, that is very severe hypoxemia. So, one of the ways, apart from blood gas, one of the ways for defining hypoxia is to look at the ratio of PaO2 to FiO2. If that ratio is less than 200, you'll have severe hypoxemia. Are we clear on this? If the ratio of your PaO2 or the blood gas compared to the administered oxygen is less than 200, you are in severe respiratory failure. So this just tells you that when it comes to respiratory failure, for you to have a complete picture of what is going on, you have to have a blood gas. However, if you do not have a blood gas, you understand this physiology, particularly remember this graph, that if your oxygen saturation is 85%, that means your PaO2 is about 50 something. So if you don't have a blood gas, if all you have is a pulse oximetry, you should be able to make an inference whether or not the patient is severely hypoxic. We're spending a lot of time on this because this is a very common clinical problem in our environment. And you have pulse oximetry even if you don't have a blood gas. And for children, if you have hypoxia and the patient is tachypneic, like you said, you can always assume that they have a mixed respiratory failure pattern because at that rate, the gas escape is ineffective. So let's move on quickly. Now let's look at all the causes of hypoxemia. If you go to it on a hill, because of the high altitude, you will be hypoxic. And if you are not very healthy, you will need extra oxygen. And that is probably because of the drop in barometric pressure as you go on a high altitude. Then alveolar hypoventilation is another cause of hypoxemia. You can also have impaired gas diffusion. That is not a common clinical entity. You can only see that in fibrotic lung disease. And then ventilation perfusion mismatch. I don't like this lecture so much because it's kind of a little bit theoretical, but it's very important. So I will focus on the two common mechanisms that you will see, which is alveolar hyperventilation and ventilation perfusion mismatch. So if you look at the cartoon that to your right, all those red dots are oxygen and the blue ones are carbon dioxide. And if you have in the alveolus the concentration of oxygen and carbon dioxide in the alveolus diffuses unimpeded through the alveolar capillary membrane into the blood if everything is fine. However, in VQ mismatch, there are different scenarios. The first one I'm considering is shunt. When you have a shunt, you can look at the blue and the red dot. The alveolar is sac, is painted black now. In clinical practice, that would mean atelectasis, that could mean pulmonary edema, that could mean that you have pus in the lung, or the lung is collapsed. So, blood continues to flow to that alveolar segment, but because the lung is collapsed, either from atelectasis, pleural effusion, pneumothorax, or even just empyema, there is no ventilation, but there's perfusion. That's shunt. And so, in your patient with sickle cell disease, acute chest syndrome, in your patient with significant atelectasis, your patient with pleural effusion, the cause of hypoxemia in that case is what? Shunt. Are we understood? Yeah, because you are ventilating from above, but the air is not going through the alveolus, but you have just blood flowing through there, so there's no gas exchange. The normal scenario is in the middle where ventilation and perfusion are matched. The extreme, and I understand, and I had when Dr. Dole was explaining this, is dead space. Dead space ventilation occurs where, when the gas, the air and the oxygen and carbon dioxide is not utilized in the gas exchange. Why? Because of inadequate blood flow to the alveolus. So that's why you see this. You see this is showing that there is no blood flow here, but there is adequate ventilation. It's the opposite of shunting, where there is good blood flow but poor ventilation. Here, there is good ventilation but restricted blood flow. So the question will be, what would be the cause of dead space ventilation in clinical practice? Anybody? What is the scenario that will cause reduction of blood flow to this alveolar segment, causing dead space ventilation? If you understand that, you will know why babies always have mixed respiratory failure. Even if they have a primary hypoxic failure from shunting, there's always a dead space component that leads to hypercapnia and CO2 retention. And then can you tell me clinically what can cause reduction in blood flow? Anyone? Pulmonary hypertension. What is how does that do that?
That prevents the flow when there's hypertension.
Okay. Increased pulmonary vascular resistance.
Yes.
So there is no blood flow. Any other thoughts? What if this alveolus expands and the pressure within it is very high and it presses this vessel? Under what condition will that happen? Anybody? Clinically. bronchiolitis. That baby has bronchiolitis. Air trap. Anytime you have air trapping and increase in alveolar pressure, it compresses this vessel, so you have dead space ventilation, in addition to whatever else is going on. So typically, it's a mixture of shunt and dead space that causes the gas exchange abnormality. And if you now put a patient on the respirator and you increase your PEEP, and the alveolar pressure increases, it also compresses this vessel. So, meaning that anytime you have a low functional residual capacity, or your FRC is higher than normal, you are likely to cause stenting of the blood supply to that alveolus. So the only thing you need to remember in this lecture is that in most babies, it is a combination of dead space ventilation and shunting that causes the gas exchange abnormalities. Okay? I won't talk so much about high altitude, so let's go back to this infant. He was dyspneic, he has hypoxemia and wheezing. Anytime you have a patient wheezing with respiratory failure, that's evidence of lower airway obstruction. And with that, you have carbon dioxide retention. So again, that will explain what we are seeing here. The blood gas in room air is 732 with a PaCO2 of 58 and a PaO2 of 50. If you go back to this gas, PaO2 of 50 here, see what it corresponds to in terms of oxygen saturation. So that is the reason that this child, even from the history and physical exam finding, before you get the blood gas, you can almost guess that this patient has a mixed respiratory failure, which is hypercapnia and hypoxemia. And the reason I say you can almost guess is that I'm hearing wheezing, and I know that there's air trapping, and I know that there's going to be increased alveolar pressure, and I know that there's going to be dead space. And with dead space, you have poor gas exchange, which includes hypercapnia as well. So that leads us to causes of hypercapnia: alveolar hypoventilation and increased dead space. It happens that in this particular patient, he was tachypneic. So you cannot say he was hypoventilating, but he has significant increase in dead space. So in this case, this hypercapnia in this example is more from dead space. But in general, hypoventilation can cause hypercapnia, like the case that we discussed yesterday, when the patient has opiate poisoning and was breathing 8 times a minute. That is classic hypoventilation. And so you expect hypercapnia. But then if you are breathing at 60 times a minute, or you have significant dead space, your work of breathing is ineffective because of that dead space, and therefore you have hypercapnia. Okay? Now, this is important because I'm talking of causes of increased dead space. And that reminds me of your patient with diarrhea and dehydration. Hypovolemia and low cardiac output is listed here as a cause of dead space. This is the main reason I want to give this lecture, because of this pathophysiology explanation. It's very important for us to think about that. From this diagram, why would hypovolemia and low cardiac output be classified as a cause of increased dead space? Anyone? Can you start again? Okay, is
because it's
reduced. So you can have reduction either due to a mechanical obstruction, like you have a clot, pulmonary embolism, or you have actual increased resistance from pulmonary hypertension, or increase in alveolar pressure. But if that's not the case, you may not have adequate blood flow to the alveolus if you are dehydrated and hypovolemic, or if your cardiac output is low. So that's also in your patient who has bronchiolitis, who is breathing about 80 times a minute, who has increased insensible loss, has not had enough to eat, maybe has a fever as well, so he's dehydrated. And on top of that, his wheezing is obstructed. You can see that this patient has all the reasons to have a dead space, increased dead space. So think about that. When you see a tachypnic child who has not eaten well for 2 or 3 days, giving them volume to correct the dehydration, in addition to your treating the respiratory problem, can help with improvement. And I mentioned high airway pressure, so remember all of this when you're taking care of this patient. How will you treat the hypoxemia here? This is some of the things that we discussed yesterday. Supplemental oxygen and treat the underlying condition. And there are different ways of providing supplemental oxygen. Either you use devices with high, moderate, or low oxygen concentrations. It will be about maybe about 25 to 30%. Then the next thing you want to do if the patient is really sick, particularly those ones with shunt, you want to use a venturi mask and commonly a non-revealing mask. So think about how much oxygen you want to deliver when you want to when you want to apply supplemental oxygen. So nasal cannula will not work for a patient with significant pneumonia and shunting because we want to deliver a higher concentration of oxygen. One of the things we use now, which I don't know if it's available, Dr. Kimberly, is the high flow oxygen device.
Not many centers.
Not many. Do you have high flow at Ibadan?
No, not yet. Okay.
Because these days, high flow is actually preventing us over there from intubating a lot of patients, particularly the RSV and stuff like that. But all you need to know is that for this class, think about the underlying pathophysiology and how much oxygen you want to give. Nasal cannula is not very effective if your patient is in severe respiratory distress or failure. You want to give a higher oxygen concentration. Okay. I'm going to mechanical ventilation. So that's where I'm going to stop here. Are there any questions or anything that needs to be clarified?
Thank you, sir, for the presentation. I know there's PIP and there's PEEP.
Okay.
I wanted you to explain the differences between
the PIP is the PIP, and the PEEP is the PEP. When you put a patient on mechanical ventilation, the PIP is the peak inspiratory pressure. And that is determined by 2 factors, your airway resistance and the lung compliance. For the PEEP, the positive end expiratory pressure, end expiratory, when you expire, you don't expire all the air in your lungs. That's why you hear people talk about physiologic PEEP. Why? Because your surfactant prevents the lung from emptying completely. So you can maintain some end expiratory pressure. Now, in lung disease, we found out that if a patient has pulmonary edema or atelectasis, if you increase that end expiratory pressure by mechanically applying extra pressure at the end of expiration, you will open up the alveoli. So in mechanical ventilation, we talked about those 2 pressures, the peak inspiratory pressure and the positive end expiratory pressure. In patients with hypoxemia and significant shunt, you must go up on the PEEP, the PEEP. The PIP, though, will change based on the airway compliance or resistance.
And you know, there's no way I can talk about this without going into details of mechanical ventilation, which is not included in this syllabus, but I will answer it anyway. Because if you put a patient on respirator, you have two modes. You either do a volume mode where you set your tidal volume, or you do a pressure mode where you set your PIP. If you do the volume, the PIP is going to change each time the machine delivers a breath to the patient based on how sick the patient is. So if I have a child with pneumonia and also has pneumonic effusion, so what do you think the compliance of the chest and the lung will be? Poor or no? Poor. And that patient has secretions in the airway, in the bronchus. So what happens to the resistance, airflow, is hard. So the combination of that poor compliance and high resistance, if I give that child 6 mL per kilo of tidal volume and the kilo is 1060, the PIP predicted for that volume, if there is no increased resistance and compliance, maybe the PIP should be about 10 or 12. What do you think it will be in that child? High. So when you are hearing PIP, you are thinking more of the pulmonary mechanics. When you are hearing PIP, you are thinking more of maintaining the airway open. And so that's kind of the language we use for mechanical ventilation. Any other question? Yes.
Try to improvise the CPAP.
Okay.
We try to improvise. So we actually do some degree of this in newborn and even in older children. So it may not be a bad thing to talk about non-invasive ventilation.
All right. So I have to talk about non-invasive ventilation. The primary use of non-invasive, I must tell you the reason they say non-invasive is that we are delivering the pressure, the positive pressure, without putting an endotracheal tube into the trachea. That's what non-invasive is. Other than that, the concept of peak inspiratory pressure and PEP is still relevant in a non-invasive ventilation. The primary reason you do non-invasive is one, to augment oxygenation and ventilation. So if your patient comes with hypercapnic failure, you want to augment ventilation. If your patient comes with oxygenation or hypoxemic failure, you want to improve oxygenation. If your patient has mixed, you want to improve both oxygenation and ventilation. That means you need to have your goals clearly stated when you are using non-invasive ventilation, because that's going to determine how you set your machine. And then you have to use it in an alert and cooperative patient. Why? Because you are putting the mask on the face and you are setting a pressure. The way I have seen it described is if you are driving your car on Lagos-Ibadan Expressway and you open the window and you stick your head out of the window and the car is going at 60 miles per hour and you see the gush of air coming to your face. So this patient may not tolerate the mask. But there are so many interfaces that we use these days. What kind of interface do you use? Do you use just the mask? Or do you use nasal prongs? Yes. So you have different kinds of interface to help the patient tolerate the non-invasive device. Nasal prongs. Now we have nasal mask, which we just cover the nose alone, and then there's a full face mask. All depends. Then the other problem is leak. If the mask is leaking, then the pressure you are trying to apply on that patient may not be sustained. So in pediatric, we may have to at times use sedation to help them. But how do you sedate somebody who is already in respiratory failure? That brings you to the kinds of sedatives you need to use when you are doing non-invasive. At times we do ketamine, at times we do Presidex. I don't even know, do we have Presidex in Nigeria? Dexmedetomidine?
Not yet.
Not yet.
Well, we haven't gotten it in Ibadan. I asked a few people in Lagos. Alpha Pharmacy is somewhere there. When you come, you can ask.
Yes, because if there is a list of things that you need to have, I think you can make a case for getting the Presidex, because the Presidex is just like clonidine. I'm sure we have clonidine here. It's an alpha 2. It will cause sedation without causing respiratory depression, kind of like ketamine. So, number 1 and 2, patients who have a lot of secretions, because we have to take the mask out and suction, may not tolerate it. Timing is important. If the patient is going on non-invasive and does not improve within, they say here, 48 to 72 hours, I actually have, I would say, if I don't see a turnaround within the first hour, if the patient is showing sign of improvement, then I leave and I come back and check. Because why? If you delay invasive ventilation and you're not monitoring your patient who is on non-invasive ventilation, they can go into cardiopulmonary arrest. So monitoring is important. Secondly, let's look at the terminology. Some people call it continuous positive airway pressure. Some people say it's non-invasive positive pressure ventilation, MPPV. And some people say it's a bi-level positive airway pressure, BiPAP. The BiPAP is easier to understand in the sense that when you set your peak inspiratory pressure, that helps with ventilation as much as possible. And you can adjust your positive and inspiratory pressure to improve oxygenation. So that's what they call that BiPAP in that setting. So this is the recommended setting for non-invasive ventilation if you are using a bi-level device. If you are just using CPAP, CPAP is just continuous dispensing pressure, just like you apply PEEP. But BiPAP is the ideal for respiratory failure because you can adjust the IPAP and the EPAP. What is IPAP? The IPAP is inspiratory positive airway pressure, and you set it at 8 centimeters water. EPAP is expiratory positive airway pressure, and for toddlers 1 to 2 years, you start at 4 centimeter waters. And then you have a backup rate which you can adjust. The backup rate is age dependent. If I'm putting a 3-year-old on BiPAP, I can set my rate to mimic the normal ventilatory rate for a 3-year-old. And you can see that less than 12 months old babies, you just use continuous positive airway pressure. That is more or less like CPAP. I mean, that's more or less like PEEP. You just increase the end expiratory pressure a little bit. Under what condition is that useful? If you have a patient who may have atelectasis or lung collapse, you want to open up the alveolus by applying CPAP. So in older children though, more than 2 years, your IPAP start at 10 and your EPAP at 5. FiO2 at the beginning will be set at 100%. And again, backup rate is age appropriate. So if I'm putting a 16-year-old on BiPAP, I will set my rate at about 18 to 20. If I'm putting a younger child, my rate is going to reflect the physiologic respiratory rate for that age group. That's what they mean by age appropriate. So let's say that that's the start point. What do you now do if you have somebody with hypoxia or hypercapnia? How do you adjust the setting? So, for hypoxemic respiratory failure, your ventilation is not the issue. is your oxygenation. So your main target here is to make sure that you give the patient enough PEEP, which is more or less your EPAP. But if you start at 10 of IPAP, and your EPAP is 5, and you're looking at your pulse ox, then you titrate your EPAP in 2 centimeter water increments. So you go to 7, then you go to 10. You come in increasing slowly. But the rule says you should keep your IPAP and EPAP gradient the same. Otherwise, you would your ventilation will be ineffective. What am I saying? If you keep your IPAP at 10 and you keep increasing the PEEP, there is no gradient for ventilation. So while you are going up on your EPAP, you must simultaneously go up on your IPAP to maintain the same gradient. The gradient at the beginning is 5. So as you are going up on your EPAP, you must go up on your IPAP. This is a very important concept. Even though your target is not ventilation, it's oxygenation. And like I said, for oxygenation, you need to increase your PEEP. So if you decide you are going to increase that, you must also increase your IPAP so that your IPAP to EPAP gradient remains the same. Fast forward to hypercapnic failure, where you are interested in getting rid of CO2. In that case, you're targeting your inspiratory positive airway pressure. You want to increase your ventilation. So let's say you start at 10 of IPAP and your EPAP is 5. It is your IPAP that you want to increase now. And in this case, you are not maintaining the same gradient because to effectively remove CO2, the IPAP to EPAP gradient must be higher. So I will keep my EPAP the same and keep increasing my IPAP. So those are the 2 subtle approaches. So in summary, there are 2 ways. If you are dealing with a child who doesn't have atelectasis and a little bit of hypoxemia, you can just put the patient on CPAP. And that does not affect your ventilation. So the IPAP is the ideal replacement for invasive ventilation. So if you have BiPAP, you should be able to take care of so many patients because you can adjust your IPAP or your EPAP depending on whether you are treating hypoxic respiratory failure or whether you are treating hypercapnic respiratory failure or whether you are treating both. If your patient has a mixed failure, address oxygenation first by going up on your EPAP to achieve your target SpO2. Then you can increase your IPAP EPAP gradient. You can increase your IPAP EPAP gradient to your target goal. It's except you have seen, how many of you have BiPAP in your hospital? Okay, so you can see why I try to avoid this topic. But to be honest with you, if somebody comes to you, your CMD, and says, tell me what equipment that you need before you buy ventilators, you can say BiPAP because it will help BiPAP and high flow. So that's, if there is any question for clarification, let's hear that. But I can't help that if you don't have the BiPAP machine. Because, yes, what's the question?
Yes, sir. Please, would you explain the concept of F5 fraction of inspired oxygen? That's another thing that's just
We typically, because FiO2 is measured in percentage, so the highest is 100% oxygen. So when they say a fraction of inspired oxygen, at times if you say 1, you are saying relative to 100%. Everything is relative to that 100%. So if I say 30% oxygen, My fraction is 0.3. So that's the kind of way I'm seeing it, yes. Any other question? Okay. Why don't you take like a 5 minutes so, because the next thing we're going to do now is the scenarios, and I have to set up. So you can have 5 minutes to move around before we get there.
Give fluid now, give 10 per kilo of normal saline, and in the closed loop communication, you're telling me 10 cc's per kilo of normal saline given. Compare that to a situation where everybody's talking at the same time. Everybody's giving instruction at the same time. And you can imagine what the outcome of that resuscitation effort will be. This is standard procedure. There is no, oh, this is no. A dead person in Nigeria is a dead person in America. We just have to organize ourselves around situations. So the advantage you have is that when you go back to your institutions, you can organize a team that will be responding to emergencies. And if yourself, you are there, even if you don't have a team, if you are there, you take ownership and leadership. So I want to use this as an example. I also want to tell you that in most cases, you may not have a monitor. So I want to be realistic of our practice environment. However, you do not need a monitor to know, to identify who is dying. In this scenario that we're going to talk about, if this baby was brought in lifeless, and the mother is saying that there are only two possible readings. Either the patient is bradycardic and you cannot feel any pulse, or is asystolic. In that case, you need to start resuscitation. So what we are going to do, I'm going to be the one leading the code. So I'm responsible for anything that goes wrong here. Remember yesterday we talked about bag mask ventilation. See the ball of your palm with the head tilt. And you put the mask, you see your thumb and index finger makes a C on the mask. You hold the mask and you bag. When you bag, you compress 15 times, there are 2 of you, and your compression to ventilation ratio is 15 to 2. Because this baby is very fragile, I'm going to have you compress here. And if you are compressing right, you count 15 and then whoever is ventilating will ventilate twice here instead of doing it on the same baby. Because I noticed that baby there is almost worn out from the poor baby is crying. So in this was a 2-year-old that the mom just rushed in and said, Doctor, oh, you don't have time to take history at this point. You are responding to the situation. Sister, this child is bradycardic. Doctor, start chest compression. Dr. Rodriguez, start. You are in charge of ventilation. Dr. Tayo, you are IV. Put the IV on the patient here. Just say IV set. Are you counting out loud?
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Do you have an IV?
13, 14, 15, 16,
Yeah,
17,
give 10 cc's per kilo of saline.
2, 8, 9, 10, 11, 12, 15.
Continue chest compression. We are still in asystole now.
7, 8, 9, 10, 11, 12, 13, 14, 15. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
When it's 6 minutes left, you also you repeat the
14,
explanation.
15. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
long have we been doing the CPR now?
About 4 minutes.
4 minutes, okay. Yeah. So 4 minutes, you want to switch compressor. Thank you. Switch compressor. Let me know when we are at the 6-minute mark to repeat the epinephrine. The epinephrine should be given every 3 minutes, 3 to 5 minutes. Can you repeat another 10 per kilo of normal saline, please?
10 per kilo of normal saline.
Oh, okay, wait a minute. Okay, we're back in sinus breathing. Okay, they want the respiratory rate is direct. What are you looking at? Okay, so this is now the time you go and meet the mother and start to say Mama Kilode. You cannot be Mama Kilode when that child came in almost dying. So the child is relatively stable now. What are you going to do from this point on? Anybody? I will, yeah? Maintenance fluid. Put the patient on oxygen. Maintain your SATs at least 92 and above. It can be 92, 90, because you don't really know what's going on. Yes, blood glucose, because maybe if the patient was found, people have been hypoglycemic, so you give, if you want to correct the glucose, what do you give? How many cc per kilo? For that, unfortunately, you have to do per kilo. Okay. So you give that, so you do point of care glucose repeatedly, and then you put the patient on maintenance fluid. The maintenance fluid must have dextrose in it, either D5 or D10. Will you put electrolytes in it yet? Why not? Yeah, we'll just finish resuscitation. Maybe the patient is not making urine. Yeah. Then you want to now do, you can do a blood, because it could be sepsis. You can do a blood culture, do your E&U and everything. Does anybody have any questions about the flow? Because this is what we're going to be doing now in groups. Yes.
When do you stop? Because he was not supposed to stop when the heart rate came back. So is there like a duration after that?
No, he's supposed to stop when the heart rate came back. Remember, his heart rate was 26. He was lifeless. He was found, like if one of those babies found in a dumpster and was brought into the hospital. Probably cold too. Probably hypoglycemic. Probably has an acidosis from dehydration. Nobody knows how long. So you have to now, this is what they call the post-arrest care. You can't just say, oh, because the patient now has a heart rate, that's the end of the story. So this is the time you're going to now sit down, you divide yourself into a group. Somebody go and talk to the parents, and somebody is still continuing the post-arrest care. Post-arrest care, you repeat. If you don't have a blood gas, you do your E&U. If your E&U comes back, and your bicarb is like 12, you already assume that this patient has metabolic acidosis. And because he was not breathing when you started the resuscitation, he probably has hypercapnia as well. So the question now is that now that this patient is like this, is he spontaneously breathing? If he's not spontaneously breathing, what is the next step? So again, I know your practice situation is difficult. The thing I want you to take away from this scenario is that if you are in the middle of nowhere, if you don't have a respirator, you don't have CPAP machine, but you can resuscitate this guy and then be calling people like Dr. Akindole that, okay, I don't have anything here. This child, resuscitated this child to the best of my ability. This is the next thing you can do. As opposed to the child comes in, you did not recognize the seriousness of the situation. You did not check the blood glucose, you didn't do anything. So that's what the society is trying to correct. That those physicians who are in smaller hospitals should at least be familiar with the basic understanding of the pathophysiology of critical illness and how to approach it. Any?
Yes, sir.
Yes?
Sir, if I'm taking blood gas using a venous, arterial, or capillary sample, is there any difference in the interpretation, or is it the same?
The pH, it's 0.0008 different between venous and arterial. So the pH you can rely on. The PO2 is different. Venous PO2 is usually in the 40s. Arterial will depend on how much oxygen you are giving. Remember that equation we talked about, whether you are giving, so if I'm giving 100%, you expect about 500, but oftentimes you get less because there's something going on, a shunt. In this case, you don't have the time to do an arterial because that means you have to look at the radial. A venous is fine, but the venous, in a patient who came in lifeless, the venous sample is going to be misleading. So the only thing you can get from that venous is probably your pH.
Okay.
It's only now that the child is better that you can try to get an arterial or just do a capillary if the cap refill is better. So post-arrest care, control fever, check glucose, make sure you correct hypoglycemia, correct acidosis, do maintenance fluid, and then do ancillary testing because you do not know why the patient showed up. This could be congenital heart disease, for example. So if the blood pressure, do we have a blood pressure? No. So it's taking the blood pressure now. If the blood pressure is abnormal, then you react to it. So what I want us to do now is question. Yes.
Yes, sir. So the patient is in systole and we keep on bagging the patient with chest compression. For how long can we continue doing that? That's
ethically.
Huh?
I'm married to the question. Ethically, when do you stop?
Good.
Then the second question is, I want to be sure if I understood the concept of the claim, aim, and the name.
Okay.
The name, did you mean the condition the patient
The condition. It's not your own name.
And then I understand. Then the claim is you assuming
leadership.
And then the aim is
aim, you are aiming your team. You are assigning specific responsibility to your team, aiming them toward a common goal. This was actually developed by the Simulation Center at Harvard. I went for a training there, and that's what they use because the question is always, have you been in a situation where you are resuscitating a patient? How? Yes. So from now on, make sure, if you are the leading physician, that when you are there, it is organized. Because at the end of the day, everybody will be shouting and talking and nothing gets done. So naming the situation is that once you start talking, nobody else gives orders except you. So one of the things you can do to show that you benefit from this course is when you get to your own hospital, form a team. And then you now know that this place has a SIM center. Place with Dr. Akindole, and occasionally, maybe every 6 months, once in a year, practice. Because if you don't practice, you will forget it. Yes, any questions? Oh, I say I'm not sorry. There's the ethical question. Remember, I was asking, that's why the timer is important. Remember, I was asking, how far have we gone into the resuscitation? By standard, you have to give epinephrine every 3 to 5 minutes. If I'm running and it was witnessed, I can go for 30 minutes. But that is a stretch for pediatric patient. If the child was brought in with a fixed dilated pupil, meaning most likely dead, maybe 15 minutes. But if it's a child that was found somewhere, I don't know how long the child has been there. After my third round of epinephrine, which by definition is either 9 to 15 minutes, I will stop.
So that means we shouldn't send the WED02.
So because in my own practice environment, I quarrel with the ER physician a lot because if you continue long enough in pediatric patients with a good heart, the heart will come back. But then what happens to the brain?
So neurological.
They are just neurologically devastated. So that's the ethical question there. But at times, there have been prolonged codes with successful outcome. So that's why you, as the treating physician, you have to kind of use your judgment and say, is this the kind of patient that I want to do a prolonged resuscitation on, or I want to limit my resuscitation to about 10 to 15 minutes? Any other question? Because you need, yes?
How frequent do you give normal saline?
Normal saline, you could, that has no limit. You remember when we do the 6 H's and 6 T's, hypovolemia, hypoglycemia, hydrogen, which is acidosis, hypothermia, and hypokalemia. So all of those would apply in this case. So the dehydration part, I have to correct that. So it's not unusual to give up to 3 10 cc per kilo normal saline boluses to improve perfusion to the lungs, to the bigger organs. Remember, even on the last lecture, we talked about how hypovolemia can cause dead space ventilation. So there's no limit to that. But if you suspect that this is cardiogenic, and there's no way of telling us except you get an x-ray and you see a big heart, or you listen and you hear a murmur, then you have to be careful how much fluid, even how much oxygen you give. Because there are some lesions, like doctor-dependent lesions, where you need to reduce the oxygen and put them on prostaglandin. That's one of the questions they were asking yesterday.
So is there a split, like a protocol on the maximum quantity of normal saline you can give?
There is none, but there's a guideline on how much to give in different scenarios. If you suspect cardiogenic, there's 5 to 10. Whereas if not cardiac, you are given 10 to 20. Now, there is a study from Uganda that looked at resuscitation practices in Africa. I think it was Kenya. And they found out that the outcome was poor when they were using guidelines based on recommendations from overseas, like 20 cc per kilo for shock. So if I'm practicing here, I would do it in early cost of 10 per kilo. Why? Some of those kids are malnourished, they have low albumin, and you put them in pulmonary edema. And you put them in the pulmonary edema, you don't have a ventilator.
And they would also be seen in maybe referral hospital before coming to your facility.
Yes.
And they would have been fluid.
So, and then even in the United States now, they adjust the protocol that if you are in a remote area and you don't have access to an ICU, be gentle with your fluid. So if you put them in pulmonary edema, you don't have a respirator, or you don't have somebody who will intubate, then the patient dies from hypoxia, from pulmonary edema. Any other questions?
So the time is up for this.
Yeah.
Assuming the baby was actually paper white clinically while we are assessing about the fluid, should we give the fluid first, or we have to go for blood?
Oh, well, the only time you'll be looking for blood is if you have hemorrhagic shock. In other words, if it's anemia, at that point you cannot be looking for blood. Until when you get to this stage, then you can type and cross or transfuse with O negative. But if it's accident and emergency and the child is bleeding, hemorrhagic shock, then you need to transfuse. But if it's a medical situation, non-trauma scenario, normal saline is still the fluid of choice for resuscitation.
So we have severe malaria, severe anemia.
Huh?
Yes. Severe malaria, severe anemia, not just, but the commonest cause of our anemia in children is severe malaria, not hemorrhagic shock.
Okay.
Yes.
Okay. So okay. Look, I know because I did my training at Ibadan. I know nothing has changed in terms of what causes the problem. But what I'm saying is, for practical sake, let's say this patient is an older child with severe malaria and anemia and came. It is not practicable for me to tell me how quickly can you get blood from the blood bank.
1 hour.
Okay, even yes. And if you don't have O negative for emergency, you have to type and cross.
Yes, yes.
So the best thing is to resuscitate the patient first. And then once the patient is slightly stable, then if the patient now has, this is a okay blood, did we say it's a 2-year-old, right?
Yes, yes.
So this blood pressure now, I said, this is low, but his patient is stable, and I now need to give volume. I would prefer to give blood, because now I know that the patient has anemia. But I won't wait looking for blood when he came in with a heart rate in the 20s. Any other questions? No time in that. When you are resuscitating, if you give one now, you reassess based on blood pressure and pulse. If your pulse is still steady and your blood pressure is low, you can again. One of the things that for that question is that when you are giving fluid out of necessity, check for RALs and enlarged liver. Because if that is not present at the beginning, and then as you go along, you start to have crackles, it is for you. You need to slow down. So that is why the sequence of event here is that once you respond to that emergency based on the triangle, I saw this child came in, is not moving. So appearance, child looks obtunded. Work of breathing, no effort. Circulation, skin is cold, cap to kill. That's my observation. Based on that, I didn't have any time to be doing my kilodale or I'm jumping into action. But at this stage, I now do head to toe examination. Now this is the secondary survey now. We're now looking at the fontanelle, the pupil, the lips, oscillatory. That is the way you should approach all the cases that are given to you, and that's the way you should practice. If this was the clinic, they brought the child to you, the child is still talking. You can sit down and spend 15 minutes to get history. But in ICU medicine, emergency medicine is the reverse. And you have an open-ended history in the sense that as long as the patient is under your care, you keep getting the history. Because you stabilize, you go back and find out more. Okay.
So that means there will be a history.
Yes.
There will be a very quick history.
Yes.
While you
or no history at all. Because this, when this one came in, there's no history.
Yes.
You can, part of the name, claim, aim, you can designate one person to go and be talking to the family. And actually one person should be updating the family what is going on. Because now they are crazy. Somebody should be saying, this is what we are doing, this is what we want to accomplish.
I think so. I saw in one of your slides yesterday, the last line that the family should be involved in the, that's just secondly what you are saying about the updates, like maybe being around.
Some people are saying now that, what is your practice here? Do you, let's say, would you have allowed this child's mother to be here?
The first time we are not.
Dr. Akinole, what's the practice? Would you allow the mother of this child to be here?
So actually, most of our emergency rooms are not practicable. They are not designed to have the mother stay with us when we are resuscitating. However, because of the culture here, once you start chasing a parent out, some of them start screaming. So a lot of us have them hang around somewhere where they might be able to see what's happening. You know, it happened to me just last week. I was trying to, we were called to the ward for this head injured patient who looked stable and then deteriorated suddenly on the ward.
Okay.
And this time around, apparently it was even the uncle, the father's elder brother, who was the man of the family and refusing to go and all of that. You know, so, and he was standing in the way. To be fair, he was obstructing us. So we needed to do something. So we just had to get in some of the security people to come and speak Yoruba with him and say, and drag him out. So it's variable, honestly, and most people would. And the problem with our hospitals is that they don't have a policy. So they don't have a parents should not stay, parents should stay. So at the end of the day, it is the physician on site that makes a judgment call.
I think for my own practice environment, the situation has evolved from telling the parents to step aside for procedures, for emergencies, to when you ask if they want to stay. And in either scenario, there's somebody updating. My own experience, I have seen was a leukemia patient that was rushed into the ICU. I intubated, line resuscitated. He died anyway. And when they did the funeral, the mom came to thank us, saying, I was there. I saw that you did everything that you needed to do. So in a way, it can provide closure, as long as it's done politely. As far as I'm concerned, do what you are comfortable with, but you cannot afford not to give them information.
So our ICU had a policy, even before I came, before we came on as people. So I think it was 2016 when my dad died. They allowed me to be present, and they said that's their policy, that if you want me to be present. I didn't particularly want to be present, but I felt like my dad would have wanted me there. So I stayed on, and after that I discussed with them, and they said it was their policy, and I see anyone that would like to stay, as long as you're not obstructing.
Yes, and I think that's the best policy. As long as you're not saying, you're not fighting and trashing. But if you are there, if you can witness the trauma, because it's traumatic to see people pressing on your chest, on this chest, and doing all sort of. This guy doesn't have an IV, you will have done the bone marrow. Yes. Because it's been used.
So what I also notice is, like, putting one's hand at the back.
You need to raise. You are not supposed to put your hands, because I'm holding it. Because in babies the needle can come out here.
Yes.
So if it's there, it should be stable. It's not. I'm giving an example. Then you take this out, and you see this can be attached to an IV.
Yes.
At times you can have a blood return, but you may not have blood return. So the things to know. Question you'll be asking yourself is, am I in? If you are not in, it will be wobbly, like this one is not in. And if you start to infuse fluid, the surrounding will be swollen, or the back will be swollen if you've gone too far. So the teaching is, this is supposed to have a consistency of bone to help you. Yeah. Once you hear that, and it's in like that, you take it out, take the needle out. If there's no swelling around, you are fine. It might be hard when you are pushing fluid because it's bone, so it won't feel like an IV. It doesn't mean that it is infiltrated. As long as there's no swelling around and no swelling behind, then you secure it and give fluid. At least it's good for less than 24 hours. Once the patient is stable, you have blood pressure, then you can try to put in an IV or a central line. So that's intraosseous. You can put it here in the proximal tibia, above the medial malleolus, this is another site here, or in the condyle of the femur, but this is the most common for pediatrics. Contraindication if there's an infection in the bone. If somebody has tried before, don't try on that side. You have to use another leg. And you can talk to your hematologist. If you don't have a bone marrow needle, you can get, if you don't have an intraosseous needle, you can get a bone marrow needle. This is like a bone marrow needle from your hematologist. And say, I need one to be in the ER. Okay, so any other intervention, the assessment, effective communication guideline, and that's going to organizes your thought and your approach to clinical problems. Okay. Any, sir, please. Yes. Yes. Okay. Go ahead.
Okay, thank you, sir. So I have just noticed something in the environment in Nigeria particularly. There is this nonchalant attitude. When they are not in the hospital and something like this happens, and the parents or the community are calling for help. Most times, people are not able to do anything because of legal reasons. In such scenario, what should we do?
You mean outside the hospital?
Outside the marketplace. In the anywhere in church.
Because police will arrest you.
Conscience in the church. If you think you can walk away from somebody who needs help and then go home, last year when I was here, somebody collapsed in the church. And myself and my driver, I've been actually noticing the man. He stood up and he was yawning. Next thing I saw was move on. Identify yourself. I am a doctor. I think I can help. Or I am a nurse. I work in the hospital. That might give them some confidence. Then
there's a lot of religious undertones in things in Nigeria that if you get into it now and the person believes that it was an arrow from somewhere, or the person that joined them to send the arrow. So there's a lot of
talking to our family or something we are doing together for some time now, managing prematurity, so cutting edge things. We're not cutting edge, people have been doing it. We use diffuse citrate and immunity infusion. One thing we have not been able to step up to yet, and because of the causes, the factors, and we're struggling to get there. What brought me and Mr. Tilewa together so close is that a personal encounter, very personal to him. He had it done. We need to put that return alive. We need something to make the baby breathe. We need some factors. We need the amino acid. We tried Akure, we tried to do it, we tried many places, but we were able to do much. And after that, I think Mr. Tilewa went into it headlong. So you have been supplying Unimed with diffuse citrate and amino acid infusion. So having this kind of training, I think is good for us to hear from him. So let's welcome Mr. Tilewa.
Thank you very much, sir, for me. And I'm saying good afternoon, sir. On the IT room, Dr. Olubenga and Dr. Abibola, if I'm not wrong. Good afternoon, sir. It's a privilege to share this IT room with you. I've not read as much as you read. I said it's a privilege to share this table with you. I've not read as much as you have read. That's why I call it a privilege standing on the table you are standing on. Thank you very much. Good afternoon, everybody. Good afternoon, doctors. I hope you're enjoying the training. Like Dr. Akiku Miragli said, my name is Tilewa, and I'm representing Alpha Pharmacy. First of all, Alpha Pharmacy is saying thank you for giving us this opportunity to be a part of this pediatric fundamental critical care support program. And Alpha Pharmacy, some of you might have heard about us, is an indigenous company whose aim is to try to give healthcare professionals quality medications that will make you enjoy your work. And we've been doing that for over 35 years now. And we represent many world-renowned pharmaceutical companies here in Nigeria. We don't produce anything, we just go out and get the best all over the world for you. That's what we do. And we provide physicians like you with products that ensure the best possible outcome in the treatment and management of your patients. We do several things, but for the pediatricians like you, we offer caffeine citrate. We also offer trophamine. Trophamine is a pediatric specific amino acid infusion, and recommend it to prevent neonatal wastage. Actually, we recommend for every low birth weight. We know breast milk is the best form of formula, but this amino acid, when you mix with dextrose, maybe have some other supplement, it gives you a form of total parenteral nutrition. We also give postpartum surfactant and growth hormone. But suitable for this kind of program, I think it's best to talk about apnea. We are talking about critical care. So we love to talk about apnea of immaturity. And I'm not tempted to teach doctors what they know. So I'll just talk briefly and go right down to caffeine secrets. They call repeated in preterm babies, baby born in GA less than 37 weeks. And persistent apnea may be very harmful, not even me, is very harmful to the developing brain and some other organs of this baby. And why is it so important to look at this aspect? Because we know that an estimate number of 15 million babies are born preterm all over the world, and the number is increasing. And so if apnea is a problem, then this is an aspect where we need to take very seriously. And you know it's the leading cause of death among children even under 5 years old. And a few of the complications you see there, some are short-term, some are long-term. The short-term ones you will see cardiac issues. The baby come down with heart problems, brain problem. Remember, this baby is still in the developmental stage. It's still at the stage where it should still be intrauterine, but years out. So it will lead to all these complications, most importantly, breathing problem. And some long-term complications which no parents and doctors will ever want to have. And just to mention a few. Whereas Alpha Pharmacy, what we do generally, our stand is to provide the much needed medication to combat respiratory stress syndrome and apnea. And we also provide several alternatives that will improve your outcome in taking care of children with apnea. And we hope that you will migrate from using the pills and time for these children and move to the use of caffeine citrate. We market 2 major types of caffeine citrate, one from UK, Martin Day. It comes in 10 milligram per mil, and the other one from Korea, Farm Bio is the name of their company. This one has more advantage for us in this part of the world. One, because of the strength, it comes in 20 milligram per mil, and because of the cost. And the two of them have shown us the same kind of results. So briefly about caffeine. It's beta white crystalline alkaloid, and it's in the family of the xanthine. It's found in some of the food we eat. You can find it in the coffee we drink, and some leaves and some plants as well. But why is it important? It's because of what it does. It is CNS stimulant. And it is mostly, it is a stimulant, and it helps in combating apnea. The review of several trials, particularly the ushering review of trials that have been done, show that caffeine has similar effect to theophylline, but has a larger therapeutic index, and that's what gives it an edge over the aminophylline that is commonly in use around here. Caffeine is easily absorbed and has a longer half-life because of that wider therapeutic window that it has. And that allows us to use it as a daily dosing regimen, just once a day. And that means there will be no need for this routine blood level determination you need to do when you are using aminophylline. When you are using caffeine, you want to check the serum level to be sure you are safe before you administer the next one. And because you are not repeating it, it minimizes cost. Yes, I agree when you say caffeine is more expensive than aminophylline, but the number you use is reduced when you compare it to aminophylline, and then it reduces the nursing hour on the baby. How does it work? We may not be able to say specifically the exact mechanism of action, but the different results that has been seen from its use put together makes it very, very good for using for apnea. It's CNS stimulant, like I said before, and a bronchi smooth muscle relaxant. I know all of this working together will help maximize respiration. It's also a cardiac muscle stimulant and a diuretic. Let's just go through a few of the results we've seen that favors its use in apnea, especially prophylactically. It stimulates the respiratory center and then increases the minute ventilation. It decreases the threshold of hypercapnia, reducing the accumulation of CO2. This happens because it has an increased response to hypercapnia. There's also increased skeletal muscle tone. And you know, the intercostal muscles are needed for breathing as well. One of the things it does also is to decrease the diaphragmatic fatigue. Remember, these babies we are talking about are not yet fully formed. So these outcomes favor the advantage of favors what we want to achieve. It increases metabolic rate and also increase oxygen consumption. That's why it's very good. In infants with apnea, caffeine is believed to work by stimulating the central respiratory center, thereby decreasing the carbon dioxide threshold, like I said earlier. And caffeine may also increase skeletal muscle tone, decreasing diaphragmatic fatigue, and aiding respiratory efforts. So, the dosing. The recommended loading dose for caffeine citrate is 20 milligram per kg, given intravenously or enterally. That's the advantage this has over aminophylline as well. We can give it orally. And if you administer IV, the loading dose should be infused over 30 minutes. And then the maintenance therapy should be initiated with a dose of 5 milligram per kg given IV over 10 minutes or enterally. This is done every 24 hours, unlike the aminophylline that you do repeatedly 24 hours after the loading dose. Therapy should be titrated based on the clinical response and to maintain caffeine concentration between 5 and 20 milligrams per ml. So when compared to aminophylline that is commonly used around here, if you look at the dose, you see for caffeine citrate, the dose you need is between 5 to 10 milligrams. But in aminophylline, you need 10 to 20 micrograms per ml. Caffeine citrate, the daily dosing regimen favors it. But in aminophylline, you have to do divided doses every 6 to 12 hours. And for caffeine, there's no need to monitor the serum level. But you know, in aminophylline, it is expected that you do that so you don't overload the baby. So in summary, what are we saying? We're saying caffeine has a wider therapeutic index that makes it safer to administer in these small babies. And it's once daily dosing, it saves nursing time, like I said earlier. And another advantage it has is the dual routes of administration. And it does not require constant monitoring of the concentration in serum. We are glad in Alpha Pharmacy that our goal is getting achieved gradually. This is being adopted in most hospitals, particularly the tertiary institution. And we hope that since most of the professionals there have seen the outcome, we'll be able to replace aminophylline rather with caffeine cigarette. Thank you for listening.
Do you have any side effects? Thank you.
What's the price difference between the two? And the price of the Profilin too, I want to. The cost of
potency of NC2 relative to the I heard you mention that.
Sometimes we don't have it. And Alpha Pharmaceuticals and regional company are going to run for 35 years. And then I'm wondering, how old is the company going to get to before they think about manufacturing? Because you're 35 years, but you're just bringing in and bringing in. What do they think about? Yes.
Just pick up from where the last speaker ended. Yes, the Alpha Pharmacy has been doing so wonderfully over the years. Mr. Tilewa is a friend, and they have been doing wonderfully well. At least from us, from my center, the caffeine secret has been very available for some time now. My question is, I don't know, is it possible we do studies in all these things you have given us? I challenge your company. Let's come up with studies. Yes, that we are using caffeine for the past while. Let's come up with a study to even see the outcome of what we are doing. Really, in my own center, we have seen a lot of positive outcomes from the use of caffeine citrate. But you know, anything that is done that is not published can never be appreciated. So maybe we can just come up with a protocol on, maybe allow us to do this study on what we are doing. Thank you.
For the presentation, I was just a bit concerned. Looking at caffeine as it is, its effect on the respiratory center, so think about it. Thank you.
I didn't get the question.
Caffeine, I know, though is a stimulant, but it has some other adverse effects, especially in the respiratory center in the brain. So, considering that, what's your take in using it in these patients? Thank you.
Let me start with Dr. Last question about doing a study. Well, let me start from availability. Alpha Pharmacy has been around for 36 years, and while we just bring it in, and we're not looking at manufacturing. A simple answer is the Nigerian environment. The one we are bringing in, the Nigerian environment is not allowing us to do very well. Give an example. Just sometimes you ask for caffeine in Unimed H or here, and there will be a delay before you get. It's because of the issues you get at the end of NAFDAC. We bring it in, every medication you bring it in as a company must be registered. We have filed and paid everything we should to NAFDAC since 2022, and it has not been registered. So when we bring it in, they just give us permit to bring certain quantity. And it's narcotic. NAFDAC wants to trace down to the hospital where each vial is used. So sometimes we have difficulty even in bringing it in. Then, when we have standard companies, multinationals that have money to do business, living. What do you say about it? Trying. That's the basic reason why we have thought about it. 2018, we tried having a plant that does lutein and isoflurane in Nigeria. Just have a plant, best bottle it, and sell. We are frustrated. So that's the reason. It's the Nigerian factor that resulted in us. Then about the studies. Well, organizing a study may be very expensive, but presently there is someone who is fronting for one American research institute. They are about beginning a study in 5 African countries, and local has been chosen as the cafe institute. There are publications yet, yes, but there are no local publications for us to have. You know, in science, the way Africans react or relate to some of these medications are different. Our practice in Africa is different. I was talking with an IVF specialist sometimes ago, and we said they use progesterone. IVF is the first cycle. You want to give this patient a lot of progesterone to make the patient's body ready to take the conception. And they use all forms of formulations. They use pessary, they use stab, they use IM. You know why? They are very careful. We have worked so much, we have spent so much to achieve pregnancy. I don't want to jeopardize anything. I don't want the baby to be lost because of progesterone. We're saying using pessary alone is enough. And this professor said, we're in Africa. We have tried it, it does not work. I have 5 papers to prove what I am doing, and I get quiet. So there are no local papers, and some people are looking into it, some academia in medicine. So there is one about to start, related to us, a partner. It's going to be in Nigeria, 5 African countries. Nigeria is there, Kenya is there, Gambia is there, and in Nigeria they'll be using teaching hospital in Ido Ekiti and UITH. They're about to start. So very soon we will have local papers. But I'm not sure I can say that Alpha can single-handedly say we want to do a research, but we can partner with whoever comes, like they have come. Then the side effect for caffeine citrates, like you said, now I'm looking at its activities, is a narcotic, is a CNS stimulant. What's my view? My view is if the positive effect you want to achieve outweighs the negative effect and saves this baby, then we are good to go. Then the side effect, there's actually no drug without side effect. It's a CNS stimulant. If you overload too much, you know what you get. So it's a CNS stimulant. That's why it's advised to stick with a dose. What's the price difference? Usually when we talk like this, we only want you to see benefits and appreciate the value it can offer. Price is relative. Like Dr. Akikumi said, I lost a 24-week baby. I want to say thank you to Dr. Dr. Sam again, because he was there. The one just said, forget about this baby in Nigeria, 24 weeks cannot leave. What I've read in UK, US, in the pharmaceuticals, if we provide all we need to, this baby will live. And I discussed with him, and he did not discourage me. That was the first favor he did. Well, I lost that baby eventually. I'll tell you why. But I'm proud today because I made move. We sell surfactant, but at that point, we had no surfactant. I had to run to Ife. Thank you, sir, for helping me. I ran to Ife, to Adigbenbe, and she was helpful. Give me one. Caffeine was available. Trofamine was available. The amino acid. And we were able to manage this baby for 4 days. But I think, my thought now, what made us lose baby. I don't know if this will be negative. It's because there was no pediatric. I'm not wrong. There was. And after that, I Googled, what does it cost? I said, yeah, 3 million. I wish I was rich. I would have bought a set of 5. Henceforth, no baby should die as a result of this. And like Dr. Akiki said, even though this is what I do, I should go around and convince doctor to buy. But I took it as a personal thing. One, I was in it. I know what it meant to lose a baby, even though we lived just 4 days. And I knew that if we had all we should provide, this baby would have lived longer. So I took it upon myself that in my quest in talking about, we have different ranges of drugs. I have for IVF, but I focused on this. And even with the circumstances around, like the one that is giving us, the one even some hospitals are giving us when they will buy and they will almost be begging for you to get paid again. I decided to push it, and with the help of doctors here, okay. Thank you. I think I've attended
I'm sure quite a number of us are using keeping citrate and the trofamine. A lot of people are already using the factors. So we can push the message. Okay, Rob has some message.
I just want to thank Mr. Lewa, because this conference that we are hosting now, I think pharmaceutical companies and other companies in medicine should collaborate with hospitals to sponsor this kind of meeting. And I know what Dr. Akintabi went through to get this meeting going. See, the Society of Critical Care Medicine just provided slides and textbooks, that's all. So, of course, we need to help ourselves. So I think also we should give him a rounding of applause for being the exception, and that should be the trend, really, that we should have pharmaceutical companies, drug companies, those manufacturing medical equipment, collaborating with institutions for capacity building through educational activities. That's complementary. Thank you. That will reinforce the knowledge when you are thinking about it. It's simple. We are going to discuss the case of a 5-year-old who weighs 20 kilograms with skin rash and fever, who presented with septic shock. This is not, it's not unknown. We know the patient has septic shock. Admitted to the ICU and treated with fluids and antibiotics and iron. What I will do is that I will give you a set of vital signs, and I will give you a list of possible vasopressors or vasoactive agents. And based on the vital signs that you are looking at, you will tell me which of the inotrope is least likely to be the one that was utilized in the treatment of this child. So it does require you to have a fundamental understanding of how the inotropes work. So we kind of talk about that quickly while Akinwumi is getting the handouts ready for you. First of all, you know you have alpha receptors and you have alpha 1 and alpha 2. Alpha 2 is central, alpha 1 is peripheral. The only drug that I know acts on alpha 2 is clonidine and dexmedetomidine. And the way it acts, it prevents, once alpha 2 is stimulated, it prevents reuptake of norepinephrine. So it can make you sleepy. That's why we use dexmedetomidine as a sedative, and that's why you probably use clonidine to treat hypertension. So, but in terms of the vasopressors, they act only on alpha 1, beta 1, beta 2, And there are vasopressors, I won't call them vasopressors, there are inotropes that are not receptor mediated. So let's go stage by stage. Alpha 1, let's look at epinephrine. Epinephrine stimulates alpha 1. And that causes widespread vasoconstriction. And that's why you can use epinephrine in shock. Epinephrine also stimulates beta 1, which causes increased heart rate, inotropy, and tachycardia. The beta 2 effect of epinephrine causes vasodilatation in smooth muscles. And that's why you can use epinephrine in the treatment of asthma. So you can see that there's a dose response curve with epi. So if you want mostly beta 2, is low dose. If you want alpha 1, we are using high dose. And if you want beta 1, it's kind of between alpha 1, the dose range for alpha 1 and beta 1. So there's a dose response curve depending on which receptor you want to target. So epi is kind of like the sought after vasopressor of choice in critical care. We use it to stimulate the heart in a cold. We use it for support the blood pressure in shock. And in situations, even when you have increased pulmonary vascular resistance, you can use it, but it will be a low dose. So let's move on to norepinephrine. Norepinephrine is predominantly alpha 1, but it has a very small beta 1 effect, which means if we use norepinephrine, it causes primarily vasoconstriction, so you can maintain your blood pressure. However, because the blood pressure goes high with alpha 1 stimulation with the use of norepinephrine, you have a reflex bradycardia. So you don't see the beta 1 effect. And that's why it is used in hyperdynamic high output septic shock with low peripheral resistance, where you want the vasoconstrictive effect to be magnified. Let's move on to lobutymine. Lobutymine is primarily beta 1 and beta 2. So it will cause increased heart rate. It can also cause vasodilatation. It can be used in cardiogenic shock. However, if there's a tendency that, because it causes very potent beta 1 effect, causing tachycardia, in critical care, we found out over the years, particularly when I'm working with my colleagues, cardiothoracic surgeons and stuff, they don't like medications that causes excessive tachycardia. Why? Because that increases myocardial oxygen consumption in a sick heart. So it's not that you cannot use lobutymine, but there are maybe not in septic shock, maybe somebody with heart failure, yes. But in septic shock, where you are worried about oxygen consumption, drugs that doesn't cause as much tachycardia might be more beneficial. So that's why we stick with epinephrine, because we can titrate the dose of epinephrine. The other drug that we use is Mirino, which is a phosphodiesterase 3 inhibitor. I'm sure Dr. Suberu, I was close to saying sub-air because I didn't see the U. I just know as a Yoruba man, there's no way you can be sub-air. Okay, who is the doctor next to you? Have you used Mirinone before? Okay, so when I said Mirinone, why are you shaking your head in acknowledgement? I just noticed that. You know, for pediatricians, our patients don't talk, so we are very observant. We know what is going on. Everybody has heard of Mirinone before, right? Yes. So it also can be used as an inotrope, but it's not a vasopressor. It actually causes vasodilatation. However, it doesn't act on receptors, increasing cyclic AMP and causes increased heart rate. So in a shock state where you have a cold shock, patient has a normal blood pressure, but you want to increase cardiac output, you can use Mirinone instead of using the Budamine, because in that case, it doesn't cause myocardial oxygen consumption. Why? Because in addition to causing increased heart rate, it also causes vasodilatation and reduces the afterload. So in a very sick heart, Mirinone can be a good drug of choice. So we talked about dopamine, epi, no-epi, Budamine, and Mirinone. Now, in critical care, epi, norepinephrine, dopamine are first tier. But these days they say epi, norepinephrine, but if you don't have any of those, you can use dopamine. But vasopressin, which is arginine vasopressin, which is that hormone, has very potent vasoconstrictive effect. So if you have a patient who is not responding to epi, norepinephrine, dopamine, they actually at times put them on vasopressin. I'm just giving you that for knowledge. I don't think, do we have vasopressin here? But it's something that can be used in septic shock. But honestly, any patient that requires vasopressin after being on epi, oftentimes they don't do too well. So it's just for you to know that such patients exist. So if Dr. Akinkum is ready, then we will go ahead and distribute the handout, and we'll go through this exercise shortly. But that's kind of the background information that you need to go through this discussion. And after that, there's another handout that talks about selection of sedatives in unstable pediatric patients, which is going to pass around as well. Admitted to the ICU, treated with fluids, antibiotics, and ibuprofen. This is the initial vital sign on admission to the ICU. Can someone tell me what you observed here?
Which case is that, sir?
This is the case 1, 5-year-old with hyperdynamic septic shock. Case 1. Can someone tell me what you observed here? Quickly, this one is straightforward. Just the vital signs.
Tachycardia, hypertension.
Yes. And fever. Okay? So, this patient was given antipyretics. Was given fluids, and then following administration of a vasopressor, which is unknown, but is any of the one listed in the handout. This is the vital sign. That's why I gave you a brief introduction of all the vasopressors and receptors. So based on, it came in hypertensive, tachycardic,
unstable, now is hemodynamically stable. And I'm asking you, of the list of agents provided, which one is least likely to account for the observed changes? Dr. Ikena says Mirino. And I heard Dr. Akin said, can the two of you tell us why you think it's Mirino?
And because Mirino will cause vasodilatation.
Absolutely.
If somebody is septic who has, so it would have counted for this.
Okay, good. But there's something else, correct answer, but there's something else to make it perfect. What is it? No. What I want you to say is, instead of just saying septic shock, because one way you eliminate mirino is that this was a hyperdynamic, high output septic shock with low systemic vascular resistance. So it doesn't make sense to use mirino. The blood pressure is low. Mirino will cause vasodilatation. So I would not have chosen mirino here. So whatever they gave this child is probably a vasopressor. It could be epi, it could be noepi, it could be dopamine. Any of those two will account for this observed changes. Mirino, because of what is not indicated here, because of the likelihood that it will cause more hypotension. Okay? Alright, so let's move to the next case. Case 2 is a 3-year-old child who weighs 16 kilos with CHF and cardiogenic shock, presented with cool extremities, prolonged capillary refill, which is 5 seconds, metabolic acidosis, and low urine output. Blood pressure was normal for age. There was improvement in his cardiac function and end organ perfusion after treatment with one or more of the listed agents. The vital signs before and after treatment are displayed. Identify the agent or agents least likely to cause observed changes in the hemodynamic status of the patient. So, this is the patient on admission. Hyperdynamic, a cold shock from CHF, cardiogenic. Compared to this first case, it's cold shock because it's clamped down, blood pressure normal, but there's evidence of end organ hyperperfusion, not low urine output, acidosis, etc. So this is the case. So the patient was treated with an unknown and wait for the post-treatment. So now this is where we are.
What's the question?
Question is case 2. There was following improvement in cardiac function and end organ perfusion, determined from the list provided which agent or agents was least likely to cause the observed changes. Okay, what else? Blood pressure will be high, but then the perfusion will not improve. Because you are asking the heart to work against a higher resistance. Alright. So we now have the last case is a 6-month-old with tachycardia and hypotension and low urine output, who was admitted to the ICU. The patient was receiving treatment on pediatric ward for a URI and respiratory distress when he suddenly deteriorated. So this is number 3 now. this is the, yeah, 6-month-old baby. So, they rush the patient to you, and within seconds, the heart rate went from 160 to 50, and the blood pressure dropped. What would you be doing if you were there? And what medication would you administer? Huh? Epinephrine. Okay. So, the question says, a child with symptomatic bradycardia had improvement in blood pressure and oxygen delivery after receiving one of the following substances listed above. Identify the substance that most likely caused the observed improvement in hemodynamics, and you all said epinephrine. Okay. But why is it not all the other ones? Anybody? The answer is epinephrine, but you will be too cheap. You have to tell me why it is not the others. So, first of all, let's start from the obvious. I wouldn't use Mirinone in a bradycardic patient. Doesn't make any sense, right? Dexmedetomidine is one of the contraindications in bradycardia because it causes bradycardia by itself. That's the second one. Vasopressin is not a drug used for resuscitation, it causes vasoconstriction. So is epi, so is the Vidamine. So you got it right, epi is the standard drug for bradycardia and any patient that requires cardiopulmonary resuscitation. Okay, so that's that.
I've sent the gift to your page. But check, maybe this one is clear. DBS 5.
Okay, can I have my own copy then, Dr.
I think it's for more persons.
Yes. Question is, can you use atropine for symptomatic bradycardia for pediatrics? For symptomatic bradycardia in pediatrics?
Sometimes you have some patients in the pediatric ICU and you want them to have some sort of sedation. Sometimes maybe they are intubated, so sometimes we do that. Basically.
So you use it primarily as a sedative? Sedative and
analgesia.
Okay. So, thank you.
In terms of use, however, these are some of the things you have to know with use of ketamine. Number one is that it's a sympathomimetic, so it can cause tachycardia and increase blood pressure. That's why it's an ideal drug to use if you are sedating somebody in shock. However, patients are prone to laryngospasm, which is a life-threatening complication if you have not experienced it. One way to prevent that is to use atropine or glycopyrrolate pre-medication before you use it. Because why? Dr. Suberu, I see you touching your mouth right now. Because ketamine produces a lot of secretions. So you want to block that with atropine or glycopyrrolate. And you can also have post-ketamine emergent reaction, hallucination. And it can be very, very frightening to parents. So you can treat that with midazolam after or before. If you have glycopyrrolate, not glycopyrrolate, if Presidex, which I was talking about earlier. You can also use that to treat ketamine-induced hallucination. The rest of them you are pretty familiar with. Midazolam is a benzodiazepine, fentanyl is an opiate. Using them in specific situations is appropriate, but you have to be aware that they can cause apnea and respiratory depression, so you need to be careful. Then you have these neuromuscular blocking agents. Which one of them is depolarizing and non-depolarizing from that list? Anyone? You have rocuronium, pecuronium, succinylcholine. Well, the first two are non-depolarizing neuromuscular blocking agent, and characteristically they have a long half-life. Give it can last anywhere from 40 to 60 minutes. So that's, and you have to co-administer with any sedative like midazolam or fentanyl or ketamine. You can't give neuromuscular agent and use it as a sedative. You use it as a muscle relaxant, co-administered with a non-sedative. The downside is if you are going to use it, you have to be sure you can obtain an airway. Because if you paralyze the patient and you cannot intubate him or her, so that means you can only use it in patient with a secured airway. You can't give it to a patient who is not intubated because they're not going to be breathing. It's only used for patients who are already on the respirator or the patients who are about to put on the respirator. And you have to be sure you can intubate to use it. Succinylcholine, although is the only one that is a depolarizing neuromuscular block. What does that mean? If you give succinylcholine, has any one of you used succinylcholine before? Have you seen it used before? Okay. Succinylcholine will cause muscle fasciculation before it goes into effect. So if we use it in a big guy, it can have muscle pain and hyperkalemia. So oftentimes, and it can also induce very severe bradycardia in children. So you have to give atropine before you use succinylcholine. And it is contraindicated in situations where you can have hyperkalemia, like patient with severe burns, patient with neuromuscular diseases. Well, how is succinylcholine relevant? It's only used in these days if you need to paralyze somebody that you are not sure you can get the airway. Why? Its onset of action is in seconds and it only lasts 1 minute. Compared to rocuronium and pecuronium that will last 40 to 60 minutes. So it is used in special situations where a difficult airway is anticipated. There are some drugs that causes histamine release like morphine, atracurium, and cis-atracurium. Those ones cannot be used in situations where you are worried about hemodynamic instability. So, in shock, I will use ketamine. If I'm dealing with an asthmatic patient who needs sedation, who is on BiPAP or non-invasive ventilation, I will use ketamine because ketamine also has a bronchodilator effect and it does not suppress respiratory drive. If we are dealing with patients with increased intracranial pressure, one of the things you have to do is you have to hyperventilate. That's the column number 4 here. Hyperventilate, give mannitol or 3% saline. For intubation of such patients, ectomidate is advisable. Ketamine can be used. It used to be that ketamine can cause increased ICP, but these days that concern has been debunked. A little bit of fentanyl or midazolam can be used in the setting of raised intracranial pressure. For patients having seizures, lorazepam or ativan can be used to abort seizure, and so is midazolam as well. Cardiogenic shock, i.e. fentanyl, ketamine can be used. However, there has been a report of ketamine-induced cardiovascular collapse in patients who have severe cardiac disease. And the way to get around that is to use very low dose. And then, of course, finally, multi-system trauma. Again, ketamine, midazolam, fentanyl. I won't mention, do we have a terminate here? No. Anesthesia may have it. So the only drug here that I see that is relevant to your practice, in my opinion, is ketamine, midazolam, fentanyl. And for the neuromuscular blocking agents, vecuronium or rocuronium. The rest of them are drugs that you do not have in your practice, so there's no point for you to worry about that. But if you walk in the ICU with Dr. Akindole, or you walk in the ER, you must be familiar with most of these drugs. But if you are in general routine practice, I think just knowing fentanyl, midazolam, ketamine is fine, in case you need to sedate someone. Okay? I think that's how far I'm going to go with this one. Any question? When is lunch now? It's 2:30. Are you guys not hungry? Because I don't eat lunch as such. It's a serum sodium. So if you get an E and U on this patient, and the sodium is 140, is that the true sodium? Yeah, dehydrated, the sodium should be high. So the sodium is 140. So are you saying it should be lower or higher than that?
It should be higher than that. It should be lower because they are dilated.
No, higher than
To be
that.
higher.
It should be higher than that.
To be higher.
because-
To be higher.
Why is it higher? This is an important point. Huh? Yes, so that and you are giving insulin concurrently, and insulin drives potassium. So as soon as you start insulin, you must start to replace potassium. But there's also a problem with sodium. Okay, let's do this. Hypothetically, what if the sodium on this is not given? Let's say the sodium is 145. I want to make a point that this patient sodium is higher than 145. It is really 145 because the glucose is high and the glucose absorbs water, so there's some degree of dilution. So you need to, that's why you calculate the corrected sodium in DKA, and there's a formula for that. It's let's say your sodium is 145 minus 100 times 0.06. Whatever you get, add it to the sodium that you measure in your E and U. That's your true sodium. Why is that important? As you correct the hyperglycemia, you see the sodium is rising because that's the glucose is going back to normal. The sodium will be rising. If the glucose comes to near normal and your sodium is still dropping, then you are the one giving too much fluid. And the risk for pediatric decay, there are one major risk is cerebral edema. And it can occur because of administration of too much fluid or sudden drop of your glucose concentration. So in this case, when this patient was obtunded, it was because of the rapid drop. Your glucose will not drop more than 100 milligrams per deciliter per hour. So to avoid that, don't give half normal saline bolus, regardless of what the sodium is. Give normal saline. Don't give insulin bolus. Start insulin as drip. And once you start your insulin drip, you can start adding potassium to your fluid. Okay? We already mentioned everything that was said here. Case 9, patient with BPD. This is interesting. Let's use the word, do we use the word BPD down here, Dr. Akindole? Okay, so this patient has a premature baby who has bronchopulmonary dysplasia, which is kind of like adult equivalent of COPD, chronic lung disease. Admitted with respiratory syncytial virus, bronchiolitis. Patient, because of his lung disease, is on chronic home medication, which includes the following: albuterol, chlorothiazide, spironolactone, prednisone, and oxygen. This is the vital sign. What are you worried about in the vital sign? Anybody? So you have hypothermia, hypotension, tachycardia, and despite 2 boluses of 20 per kilo, there is no improvement in the blood pressure. What are you doing next?
Give steroid.
Why do you give steroid?
Because once a child is on steroid on a prolonged basis,
Yes.
whenever they are sick, you give more steroids.
Okay.
Because the adrenals will not respond. The steroid has knocked off the adrenals.
Okay, so what do you expect to find if you do an E&U on this patient? Hyperkalemia, hyponatremia, hypotension, hypothermia are all suggestive of adrenal axis suppression. So you should suspect that. Correct hypoglycemia in adrenal insufficiency, we already talked about that. If you are using 10% glucose, you do 5 cc's per kilo. If you are using D25, you do 2 mils per kilo. Isotonic fluid boluses for blood pressure, and then hydrocortisone, which has a mineralocorticoid effect, will also be given. Key points: suspect electrolyte abnormalities in patients who are critically ill. Basic chemistry check, because as you've seen, you can see all the electrolyte abnormalities. Consider oral replacement of electrolyte if possible. IV replacement may be indicated, or we are aware of complications, particularly with potassium. Avoid use of hypotonic maintenance fluid, especially in patients at risk for SIADH. Electrolyte disturbances are commonly seen in patients with metabolic dysfunction. A good example is your DKA patient. Management of metabolic diseases such as DKA, acute adrenal insufficiency, hypoglycemia, and DI should include monitoring of vital signs and lab values. Questions?